Hi, welcome to our Interventions for Tone Abnormalities PowerPoint. We are going to talk in this PowerPoint presentation about high tone and low tone and what to do to alter tone. But first, we have to talk about what it is. So muscle tone is the central nervous system's expression of tenseness or tightness in muscles that is native to each person. So each of you has a native muscle tone. Some people are a little higher tone, some people are a little lower tone. You can tell when you watch people walk, people that have their feet turned more outward, what people used to call duck-footed, if you will, and have their legs more apart and sort of swish a bit and sway when they walk. Those people tend to be a little bit more low tone in the normal range. And people that are a little higher tone are people whose feet are closer together, their toes point in a little or straight, and they tend to bounce up on their toes when they walk. Those people tend to be higher muscle tone. Some people can bend over at the waist and put their hands flat on the ground. They tend to be lower tone and have more muscle and joint laxity. The joint laxity and low muscle tone tend to go together. Joint laxity means that the tendons and ligaments around the joint are looser. So someone that can just bend over and put their hands flat on the floor have a little bit more laxity and a little lower tone than somebody who tries to bend over at the waist and can get just a little past their knees. So they're all within the normal range. Now, you might be able to bend over and put your hands flat on the floor even though you have high muscle tone if you spend a lot of time stretching and you've spent time over however many months or years stretching your muscles out a lot, then you're going to have sort of conquered some of your native tight muscle tone and given yourself more flexibility. On the other side, some people who are natively rather low tone and tend to be a little bit more flexible and less strength can improve their strength by doing weightlifting and weight training and all that stuff. And those people might display more strength, but their native tone is still kind of low. So tone is that native inbred tenseness in your muscles and strength in your muscles, and that goes along with joint laxity. It is a central nervous system thing. It is your whole body. It is not just your legs or just your arms or just your hips. It's your whole body because it's central nervous system. So if a child has high muscle tone in their legs, they have high muscle tone in other places also. It's not just in one spot. It can express itself differently in different parts of the body. And there are some typical patterns that tend to happen, which I will talk about as we move forward here with respect to muscle tone. And there's things that we typically see happen. At any rate, peripheral nervous system issues are things like Erb's palsy. Erb's palsy is a stretch injury to the brachial plexus, and that causes weakness, lack of muscle innervation in the affected arm, and lack of active range of motion. That is not a central nervous system issue. That person probably has typical muscle tone elsewhere and only has that one arm that is not functioning properly. That is a peripheral issue. So we have to know the difference because we're going to treat them differently. Hypertonia is high muscle tone. Hypotonia is low muscle tone. Athetosis, someone who is athetoid has poor graded movement. So they can't grade their movement. So they're either in full extension or full flexion. They can't do that in between a balanced muscle movement where the flexors are slowly giving way while the extensors are slowly kicking in. They can't do that. They have full flexion, full extension. And mixed tones, a lot of our clients have both high and muscle tone in different parts of their body, which is an interesting moment. Poor muscle tone, either too high or too low, or athetosis, limits both stability and mobility. So if you have low core tone, you are going to have a hard time with mobility. And if you have high core tone, you're going to have a hard time with mobility as well. So whether you have too much or too little, it's never going to be good. You need that balance of a stable core off of which to move effectively. So how is stability limited by hypotonia? So this is a very common scenario that we see in children with cerebral palsy, is they are often born with low tone in the head and neck. So they have poor physiologic flexion at birth, and they look like they have low tone, which they do. As they try to move, they pull in all this tone, all these patterns in their arms and legs that end up looking and getting very tight and developing actually spasticity. Spasticity is when a muscle cannot go through the contract and relax phases that muscles are supposed to go through, and they're stuck in contract, contract, contract. They don't have that phasic relax and contract that a muscle is supposed to go through. Spastic muscles also display clonus, and that's one of the ways you test for spasticity. If you do a quick stretch to the muscle, and usually we do this in the Achilles tendon, so you do the ankle, a quick stretch in the foot into dorsiflexion. So you would put your hand on the ball of the person's foot, and you would support their calf at the gastrocs, and then you do a sharp extension into dorsiflexion, and you would feel beats. You would feel the foot jerk into jerky sort of plantar flexion movement. And if you just do it once, you feel it in the muscle. In the hand that's supporting the gastrocs, you feel it. And then you would also feel the pressure in the ball of the foot on your hand that's holding the ball of the foot. So that's how you test for spasticity. So hypotonia limits stability because you don't have a stable core off of which to work. So that child with the low head and neck tone can't really effectively pull in those hands to bring them to midline because their shoulders are kind of pinned down onto the mat. Right? They don't have that nice flexor tone in their core to bring everything together. So stability is also limited by underlying weakness that's under the hypertonia. So hypertonia is high tone, but it's high tone in spasticity. So it's that contract, 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 not contract, relax, phasic movement that builds strength. So if you get rid of the contract, contract, the antagonist muscles really aren't functioning. So if the biceps are firing, 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 the triceps have never had an opportunity to fire to balance that because they've been on stretch the whole time. So when you get rid of the spasticity in the biceps, there's no strength left in the triceps to balance that movement. So mobility is also limited by tone aberrations or abnormal tone. Obviously, hypertonia, you have a lot of tightness in the muscles and they're contracting, contracting, contracting. It doesn't allow the antagonist muscle to allow for mobility, so it's just stuck in whatever that movement is. Also, when you have hypotonia and athetosis, your mobility is limited because it's not controlled mobility. You don't have the control that you need in order to be effectively mobile. So what we want to do is we want to have a balance of flexion and extension and a balance of stability and mobility. So we need to alter muscle tone. So how do we do that? How do we alter muscle tone? How do we increase and decrease tone? So you're going to try these things out a little bit, and we're going to try them out in class, but I want you to think about them first. So cold, think about walking into a very cold room, right? You can feel your shoulders come up. You can feel your chest tense, right? So it increases our tone when we are colder. When I have a child with Down syndrome who has natively low muscle tone, hypotonia, because that's part of the disorder, I will often sit them on one of those splat mats, those little water-filled mats for babies, but I'll fill it with fresh cold water and sit them on it. And that will get their core tone to increase, and usually I get some decent straight sitting when I do that. Quick stretches to the muscle belly and quick stretches to the joint will also increase tone, and we're going to do those activities together in class when we meet. And we'll look at tapping and brushing. Proprioception, we've talked about before a little bit, but proprioception is the joint ends and the muscle. It's the sense of your joints and your muscles so you know where they are in space, and it's the approximation of those joint ends. So when those joint ends come together, like when you're walking, when you're running, when you're doing any weight-bearing activity, you increase proprioception. And that kind of normalizes tone. It can increase low tone, but it also can decrease high tone. Being emotionally excited increases tone and tends to increase overall arousal level. And we are going to try these when we get into class. What decreases muscle tone? Dorsal rhizotomy is one. A dorsal rhizotomy is a surgical procedure that cuts part of the nerve that innervates the spastic muscle at the spinal cord or at the dorsal horn of the spinal column. So it cuts the nerve root. It is permanent. There's no going back, and it is only done, it's usually done in adults with care issues. So if somebody's legs are in severe adduction so that they cannot be cleaned or toileted properly, then that will sometimes be done to allow them to be taken care of. It's only really done in very extreme cases because it's permanent. Intrathecal baclofen is actually used quite a bit. Intrathecal means that there is, it goes into the spinal cord. So there's a small catheter inserted into the spinal cord on the back. And there's a little port that's inserted, and into that port they put a medicine called baclofen. Baclofen is a muscle relaxant. It relaxes the muscle, and it doesn't paralyze it, but it does reduce its ability to fire. And it's a medication, so it doesn't cause any permanent changes. Since it's done through the spinal cord and not systemically, it does not have the effects of taking an oral muscle relaxant. So if you take an oral muscle relaxant, you feel like jello and you can't drive a car and you have to sleep and you're all very loose and not terribly functional. The intrathecal baclofen does not affect your brain function because it goes directly from the spinal cord into the muscles. So it is not systemic. And so it's usually a very good drug of choice for people with significant spasticity that is going to allow a child to still learn and grow and function and all that. Another one that is used often is botulinum toxin, Botox. Botox is, as everybody knows, used for wrinkle treatments. What it does is it paralyzes, it's a paralytic. So it paralyzes the muscles. When it's in the face, it paralyzes the facial muscles so that you don't create wrinkles, or so that wrinkles aren't visible. In children with spasticity, it's injected into the spastic muscle, very specifically into the muscle that's spastic, and it paralyzes it. So it no longer behaves like a spastic muscle. And it lasts a certain amount of time and then it wears off, so it has to be redone. Depending on the age of the child and how much they give them and all that, it lasts different amounts of time. When they use Botox on children with spasticity, they have to be very careful to get blood levels regularly because Botox is a toxin. It is unsafe to have running around in your bloodstream, especially for a child. So they make sure to do a lot of regular blood levels. So if someone's going to have botulinum toxin to reduce spasticity, you have to make sure the client has good follow through and will show up and do the blood tests like they're supposed to. Warmth decreases muscle tone. You take a hot bath, and after you're done in a hot bath, how you're all sort of loose and your muscles are all kind of loose, right? People who do hot yoga, they know that they can stretch a lot more in hot yoga than in regular yoga because of the warmth of the room. Gentle range of motion decreases muscle tone. Proprioception, again, that's one that can increase or decrease. Emotional relaxation, right? Rocking through the joint. That's if you get into hands and knees or even just brace your hands on the table and you rock through your shoulder joint, you can feel the muscles loosen up. It breaks up the muscle tone and the muscles sort of don't know which way to contract, so they relax. And again, we will try that in class together. One of the things we need to be very, very aware of when we are working with small children and doing handling of any sort is where our hands are and what they are doing. The placement of our hands is critical because our hands are warm, so they affect tone, right? If you put your hand over a joint, you're not really going to affect tone. You're not going to decrease tone much. But if you put your hand over a muscle belly, you will affect tone. You will decrease tone, right? Because warmth relaxes and decreases. So if you have a child with low muscle tone, you're going to put your hands over the joints. If you have a child with high muscle tone, you're going to put your hand over a spastic muscle to help relax it. So you want to know exactly where your hands are placed. If your hand is over a low muscle tone part of the body, you want to be stimulating it with the tapping or the brushing or some other manner to get it going. You don't want just a static warm hand over a low muscle tone muscle, because that's just going to make it more relaxed. Your hands are going to help a child fight gravity. So sometimes they're supportive to help fight gravity. And while you're supporting to help fight gravity, you're tapping or brushing to get that muscle to wake up and start firing. You're going to resist certain movements to get a child to fight against you, and that increases strength. Muscles are hardwired to push against resistance. So if you put your hand out in front of you and I push against it, your muscles are hardwired to push back against me. So if you want a child to push against you, you push against that muscle group and they'll push back. It's just what they're hardwired to do. So we want to really be careful about where our hands are on a child's body and what they're doing in that location, and be extremely purposeful about our touch. You can affect tone, range of motion, sensory status, strength, and awareness, all these things depending on where you put your hands and what you're doing with your hands when you put them there. Are you tapping? Are you brushing? Are you doing vibration? Are you just pressing? Is your hand just there for warmth? What are you doing and why? Mid-range movement is huge, hugely important. We all move in the mid-range. Extremes of range damage our joints after time. They can be very damaging. Hanging on your ligaments can be damaging to your ligaments. And you need to use your muscles when you're in the mid-range. And most of our movements happen in mid-range. It's more powerful that way, it's more controlled, and it's more effective and causes less damage to our joints. So we want to make sure as much as possible that we are encouraging our kids and ourselves to move in the mid-range, not to move at the extremes of range. Extremes of range are going to be prone to damage, prone to pain, and not very effective. In typical movements, if you think about ways you typically move, we use lots and lots of varied movements. We don't use the same kind of movement all the time. We use a lot of rotation. I don't know if you've ever noticed when someone walks without rotation, you can really tell. They walk stiffly. It doesn't look natural. All of our transition postures use rotation and mid-range control. So when you see somebody move and it looks typical or normal, you're going to notice that they move in the mid-range, that they use lots and lots of different patterns, they use lots of rotation. Atypical movements use extremes of range with no rotation or not much, and they can't achieve or maintain transition postures. What are transition postures? Those are postures that move us from one element to the next. So for example, half kneeling, when you're kneeling on the ground with one knee up and one knee down, that's called half kneeling. You can't stay in half kneel for very long. Nobody does. It's meant as a transition between being on the floor and standing up. So that mid-range control is required for a transition, right? To be in half kneel, you have to be able to shift your weight forward through the middle of that range of all of your movements and shift your weight forward fluidly. Another transition would be leaning forward in the chair before you stand up, right? So when you stand, you have to shift your weight forward before you stand. That position where you're shifted over your legs and you start to engage your quads, that's a transition posture. So I'm going to give you a little taste. We're going to do a whole PowerPoint next time on motor learning. So you're going to get a lot more in-depth information on it. But right now I want to just talk a little bit about it so we can tie it into tone abnormalities. The idea, motor learning is the process by which a new complex motor skill becomes automatic, how we learn a new complex motor skill. It's the way our body does that. We'll talk about different kinds of practice, variable practice versus blocked practice. Variable practice meaning you practice things all different ways in different situations, different contexts. Variable block practice meaning you just practice the same thing over and over and over and over and over again with very little rest break. It's important to understand motor learning along with tone abnormalities. So when we're thinking about motor learning, we get feedback from ourselves as we're learning new things. We can transfer that learning of one thing to another. For example, I can learn how to sign my name on 1-inch wide rule paper. I can also sign my name on a form. I can also sign my name with my finger on one of those little electronic pads. So we transfer the ability to sign our name to different situations. Short, varied, frequent practice allows our body to readjust and learn things. It's about our brain understanding what's going on in us, processing and problem solving while we're learning a new motor skill. Mental practice combined with physical practice is shown in research to be the best for motor learning. So what we do is we think about motor learning and we think about tone, and we want to put them together. We want to change the tone in the context of meaningful activity, motor learning. So when you're thinking about a client learning something, you want to make sure you're altering the tone in the context of them learning something that they want to learn. Learning something meaningful, age appropriate, and all that. So for example, I want a child to have better mid-range movement and in their trunk and lower extremities. So I'm going to bring an age-appropriate puzzle that the child loves to do, and I'm going to put the puzzle pieces down on the floor and the puzzle frame up on a stool, and the child is going to have to go from low kneeling to high kneeling to put that puzzle together, and they're going to work on mid-range movement and mid-range control of their quads and their glutes and their hip flexors and their abs to reach down and come up and down and up and down to put that puzzle together. I'm combining motor learning of that down and up and down and up thing with changing the tone in the mid-range control of the child. So we want to kind of put those concepts together. When you get to class, we are going to watch a video of Gracie and take a look at her tone and what's going on there.